Obesity.
Yeah, let's not get canceled.
No, please, no.
Well, welcome back. Common Sense Medicine. Melissa, this is our third one.
Yes.
And I feel like we've done good. Patients have responded. They like it. They get useful information, which is essentially the point of this podcast, which is just to get complex medicine advices and thoughts and stuff like that and just try to make it common for people to understand.
That's right. Yeah, we just want to kind of get some general information out there. This is not medical advice from us to each of the listeners. It's more just something to help make things a little bit more understandable. Definitely always consult your doctor if you have questions.
That is as perfect a disclaimer as I ever heard. Good job, Melissa. Well, for those people who are listening to the show who do not know who we are, I am Tim Chen. I am a family physician. I am trained in integrative medicine with a view in population health and specifically cost-effective population health. And Melissa?
I am Melissa Wood. I'm a family nurse practitioner with additional training and certification in lifestyle medicine.
Which is why you're here.
That's right.
Because if anything we learn is that if we neglect lifestyle, we'll just keep adding pills.
That's right.
Which no one wants to do.
No one wants that.
No, except for when we come to this shot. It's in high
Unless
demand.
it's a shot, yeah.
Yeah. So, today we're going to be talking about Ozempic, or even not Ozempic, this family of medicine called GLP-1 agonists, right? And so we're going to talk about, what they do, their role in diabetes, their role in obesity, common side effects, and then maybe what's the long-term goal with these medications? And then we have guest questions this time.
We have questions.
And we'll wrap that out at the end. So at the end, if we didn't answer something in the podcast, we'll bring it out again in the questions.
Perfect.
So Melissa, let's start off with, the biggest problem that we are dealing with in the United States. It's an epidemic and it's obesity.
That's right.
Yeah, there's no shortcut around it. I know, people try to rename it, try to make people feel better about it. But from a medical standpoint, obesity is a problem.
It is. And it doesn't have a simple solution, because if it did have a simple solution, we wouldn't be here today. We would already know what to do.
That's right. And I think, that's the first point we want to bring out to the patient. Obesity is a problem. We can just call it like it is, call a spade a spade. It's a problem. And you're exactly right. It's multifactorial. And that, when we say we're holistic, me and you, we view patients and medical problems in a holistic manner. We mean that we realize that multiple things play a role, right? So, for example, with obesity, we're talking about things like it's not just calories in, calories out. It's also what you eat, right? The food quality of what you eat, portion control. It's, hormones that are involved. We know insulin is involved. We know cortisol is involved. We know sleep, is involved. Also treating obesity as an addiction, like sugar addiction. I mean, all of these things are linked together. And that's probably why it makes obesity such a challenging thing to treat. And also why these silver bullet phenomenons rarely cause sustained weight loss.
That's right. We've talked about the silver bullet or the magic bullet before. And while we all wish that there was just one single answer that would help, there's not. Like we said, if there was, then we wouldn't be here talking about this today. So I think that just knowing that it's a very complex process that takes multiple different avenues to really make an impact is the first step in recognizing that it's not just one simple solution for everybody.
Correct. And, part of it, trying to address this problem is we know that long-term problems that happen if we do not address this issue. We know diabetes, heart disease, there are definitely cancers that are linked with obesity, knee pain, joint pain. If you ever had a parent who had a knee replacement or a back surgery, the cost of not taking care of this problem is bad. And unfortunately, in the United States, we keep getting worse. This pandemic probably caused a lot of issues with it. Obviously, us in Mississippi, this is a problem, although we're not last anymore.
Okay, yes. We're moving up the list.
But I think, unfortunately, it's because other states have gotten worse.
Maybe so.
Yeah. So that's something that we want to address and something we want to fix. So, drum roll. Let's talk about the newest thing, right? So obviously, most people have tried a bunch of things to get weight down. There's new diet fads that come through. There are new exercise fads that come through. P90X was really big for a while. And to each of them's point, they probably do something. Mm-hmm. The problem could just be sustainability.
That's right. Yeah, I think a lot of people get success with different types of weight loss programs, and it works for some people really well, doesn't work for other people really well. Most of the time, if it works long term for somebody, it is something that is more sustainable and can be incorporated more easily into their lifestyle.
Mm-hmm. Mm-hmm. Yeah, exactly. And sometimes certain things, if it's not, you can't incorporate or you can't keep it up, or there's a diet that's so restrictive that you literally feel like you're not living life, then obviously most people end up just quitting it. Even if they had good success with it, it's just not something that's sustainable.
Right.
So we've tried, people have tried things like Adipex. That's one that a lot of people use. It tries to affect appetite, affects metabolism. Actually, when it first came out, that family, Fen was one. Most of our listeners probably don't remember that generation of medication. Killed a bunch of women, taken off the market, repurposed. So, all that being said, we as a healthcare industry have gone through, the pharmaceutical industry have gone through multiple things. The United States on average spends $40 billion a year on weight loss. Unfortunately, we're just not seeing any good return on investment until a possible game changer, right? This is all over the news, yes. All over social media, yes. All over TikTok. I think it actually started on TikTok in Australia.
It wouldn't surprise me.
Yeah, that darn TikTok. We might need to get on TikTok. We need to start.
Maybe.
Fluency. I'll probably get fired. So let's talk about this drug. Ozempic, semaglutide, GLP-1 inhibitors. Really a good drug. Let's start there. The medicine works as it's supposed to. Now, last night, I was reading, late at night, biochemistry.
That sounds fun.
See, Melissa, it was a struggle, trying to get through this. But essentially, when I was reading about the mechanism of the drug, a couple of things that it does. Number one, it can make your insulin a little bit more sensitive. So for our diabetics, one big problem is insulin resistance. So it does do a little bit of that. It stops a hormone called glucagon. And glucagon, the best way to think about it is glucose is gone. All right, so this hormone gets released whenever the body feels like its sugar is low. It makes you hungry. It can make you eat and make you absorb. So that's kind of what that hormone does. But when they looked at all the mechanisms and the genetics, Lord have mercy, my eyes hurt, of how this drug works, the end of the day, what it does, it makes you feel full. And it just makes you not eat.
Yes.
And so, obviously, when you don't eat, you lose weight.
Yes.
Yeah. You want to add anything there, Melissa?
Well, I think partially while we're talking about this today, we hear a lot of people that struggle with weight loss, and they say, I don't really eat that much, I don't eat bad, but I just can't lose weight. And then when we really get digging, or if we start a medicine like this class of medicine, and then they truly stop eating or reduce their intake, then they lose weight.
Yeah.
So yeah, sometimes just, having that, just being able to kind of really have a realistic view of what you're truly eating is a good place to start. And recognizing that these medicines do just that. It's not some crazy fat melting product that's just magically going to make everything go away. It truly just reduces the amount that you eat.
Mm-hmm, mm-hmm. That's exactly right. And we understand calories are, food is sneaky. I'll be the first to admit, sometimes I'm putting away my kids' cereal, like their Lucky Charms, and I just so happen to, as I'm pushing the bag in, come back with a mouthful of Lucky Charms. And I was like, where did that come from? And you just kind of eat it and you don't even think about it and you go on with your day. And I like that. Like the first thing we do when we, this is kind of, I guess, a side note, is because this medicine makes you stop eating and we see weight loss, what that tells us before people get on this medicine is that we were eating something.
Right. We were eating something that maybe we probably shouldn't have been eating.
Right. Or we didn't
too
know.
Much of it. Yeah. We just didn't really realize, because you're right. We kind of eat things throughout the day that maybe we just don't really think count, even if it's just a handful, a sip here or there of something that has, extra calories, extra sugar, those kinds of things. So.
Exactly. So with that being said, back to the drug, like I said, all it does, it just stops you from eating, makes you feel full. And hence, a lot of people have had really good success with the weight loss. Now, when they first made this medication, it was made for diabetes, right? So this class of medication came out a couple of years ago, really showing some really good results with diabetes. So number one, when you don't eat anything and you feel full all the time, you stop eating sugar, right? Or highly processed refined carbohydrates. When that happens, blood sugar goes down. Blood sugar in the body goes down. The body makes less insulin because it doesn't need to. Weight goes down. And what we do know is as weight goes down, everything usually gets better. We had some improvement in cardiovascular outcome in diabetics. So what that means is people who are on the medication had better heart outcomes than people not on the medicine. And the nice thing with it too is it doesn't cause a lot of low blood sugar. So one big problem with diabetes and one big problem with treating, especially type 1 diabetes, not so often type 2, is low blood sugar, because low blood sugar is actually pretty dangerous. Yeah, but the nice thing is this medication doesn't really do that. Now, side effects, it had some.
Yes.
Yeah. Nausea, vomiting. Some people actually had dehydration to the point that they went into acute kidney failure, which is dangerous.
Yes.
And that can happen because people just stop drinking and eating so much that the kidneys are like, where's my water? So really, those are pretty common. And one reason people stopped taking medication was because of that. So, great diabetes drug. One big problem with it was cost. So, and we'll actually bring that up again in the end. But then the trend happened.
Yes. I think we started noticing that our diabetics were losing weight on these medications, and people caught on to that and started using it or wanting it for weight loss alone, even if they don't have diabetes. And these medications some of them are now approved for weight loss, but not necessarily covered by insurance for weight loss.
And we'll talk about that and even the whole concept of this, like the cost-effective evaluation of this medication and the long-term implications, right? So let's go on to the trend, the weight loss. So a lot of people now obviously are asking for this medication because they realize that when I take this medication, I do lose weight. So the question is, how well does it work? And is there a trial or any good data about it? And I do have a trial, which this is what I was reading last night.
Evidence-based.
That's
right
here. That's right, Melissa. And and a little side note, just because it's on the internet doesn't mean it's evidence-based.
That's right.
I think that's pretty clear. And so sometimes patients will go look on websites like mysteryillness.com, not, dogging mysteryillness.com, but studies are important. Quality of study is important. What you're looking for is important. And based on the quality, sometimes that you can extrapolate data from it. Sometimes you can't. And the way we approach it, especially on this podcast, is to be as honest as possible. And I'll do this with pharma drugs, non-pharma drugs, even during the whole pandemic policy, there are things that we will criticize because we will make assumptions based on really poor data. But the good news is this family medicine has pretty good data. And so we'll talk about it. So there is a trial. It's called the Step 4. So there's Step 1, 2, 3, 4. There's even 5, and I think they're recruiting for 6 and 7. And essentially what it's looking at is evaluating this class of medication for weight loss, specifically semaglutide, which is Ozempic, which is Wegovy, which is probably one of the two more common ones. Step 4 is very interesting because what we do know is when people are on the medication, they will lose weight. Right? And they will usually lose a significant amount of weight. But the question always is, what happens when you stop? So it's like mystery. I'm telling a story. All right. So in this trial, what they did was a randomized control trial. So that's nice. Randomization is important because some studies have biases, right? We look at the thin person. We're going to put them on the Ozempic side. We look at the obese person. We're going to put them on this side. Randomization takes that all out because you don't get to choose. It just gets randomly assigned. And what happened was one group got Ozempic for 20 weeks and then stayed on Ozempic for 68 weeks. The other group got on Ozempic for 20 weeks, but at week 20, they shifted to a placebo. And of course, the patients didn't know what they were getting, didn't know who was doing what. And what we found out is at about 20 weeks, both groups, obviously they're both on medications, they lost about 10% of their body weight. So if you were 200 pounds, that's about 20 pounds of your body weight. Then when they switched, the group who was on week 68 lost up to 17%. So you're getting closer to that 40-pound mark. So 200 pounds, you're now closer to that 160, 180 pound. The group that changed to placebo, though, unfortunately gained most of their weight back.
Yes.
Now, obviously, we don't know what happens longer after 68 weeks, but the trend was not looking good. It was going up. So 2 things I noticed in this study, Melissa, and I'll bring it to your attention and your opinion. Number 1, there was a plateau. So even at the 68-week group, they lose about 15, 17% of their body weight, but it does not go down any longer after that. It just kind of gets stuck there. The 20-weeker, unfortunately, when they went to placebo, it all came back.
Yes. And I think we see this some in practice, definitely even with our diabetics that are on these medications for their diabetes. Yes, we sometimes see that weight loss in the beginning, but it sometimes is even more modest than those reports of the 10 to 17%, sometimes even less than that. And yes, if we ever have to stop the medicine for whatever reason, it comes back. Just like if you were on any type of diet or weight loss program, if you stopped it and went back to your regular routine, you would gain that weight back. So it is one of those things that, yes, a realistic point of view, we see those results that were trialed. In some cases, we do see a pretty significant weight loss that's clinically significant. Mm-hmm. Usually with a weight loss of about 10%, we are going to see some changes in their overall metabolic health, meaning their blood sugars, their cholesterol, maybe even blood pressure. So that amount of weight loss can be clinically significant, but I think that's a small amount compared to what most people expect from these medicines. If a 200-pound woman wants to get down to, say, 140 pounds, but adding this drug only gets them down 20 pounds, it's really not as magical as we set it up to be.
Correct. Yeah, exactly. So I think the first thing with this drug is, right, there's realistic expectation of the drug. When you're on it, you can expect to lose maybe 10, 15% of your body weight. And again, when you do trials like this is the optimum condition.
Yes.
Right? This is not mom with 4 kids at home running the soccer practice, swinging by Chick-fil-A, this is the optimum, patient population trial. And that's any drug. Any drug always works better in the trial than it actually does in real world data. So we'll go ahead and put that out there. But right, there is a limit on how much this medication does. And the frustrating thing is, unfortunately, it's not like once you stop, it comes back. And it's just like you said, Melissa, anything you do, I've heard her patients say, well, I'll do all these things because I have a wedding coming up. I'll lose 20 pounds. And they'll do it, by eating better, exercising. They'll lose the weight. And then after the wedding, for some reason, they're like, I'm back to normal. And of course, all the weight comes back. Mm-hmm. And that's not exactly what we want to do. And unfortunately, this medication is just following in that exact same footstep.
Right. And I think that people even need to realize that if you are not doing those lifestyle measures along with the medication, you may not even have that much success as far as that, 10, 15% weight loss. It really takes effort in addition to the medication to have those more significant weight losses and to be able to maintain that, because we'll even see some of our diabetics lose some weight at first and then start to gain it back even while they're still on the medicine. Mm-hmm. So certainly it takes a lot of effort in addition to the medication. It's not just that magic bullet.
Yeah. And it's like you said, again, it's multifactorial. So obesity is multifactorial, meaning there's a bunch of things involved. Weight loss is the same thing. There's got to be more than I just do one thing and not change anything else and expect things to get better. Now, some patients might ask, well, 10% is fine. And okay, step back. The drug trialists, right? So after they get the trial result, the conclusion from the drug trialists is this is a lifelong medication, right? Which again, I had one patient tell me, so is cholesterol medicine, so is blood pressure medicine, it's all lifelong, except for the small fact that this drug is not cheap.
Right. I think they're onto something there, that obesity is a condition that needs to be treated lifelong, no matter what we're using, if it's some combination of lifestyle and medication or, whatever the case may be. It is one of those things that does take lifelong treatment for most people, but I don't think that we are there yet to have a sustainable medication option in this class of medications, just because of the cost and the coverage and things like that. It's just not really sustainable for most people.
Correct. Yeah. And I mean, so when people hear cost, they're like, okay, well, what does that mean? I mean, this drug, I'll put it the average. So some are a little bit below, some are a little bit above, but it's averaging about $1,000 a month. Right. And, some people will say, well, insurance will pay for it. I'll only pay $100 or whatever. I'll just give you a little background how that works. And again, I'm not a spokesperson for United, Blue Cross, whatever. I'm not a spokesperson for anything like that. But the way it usually works is they will charge the insurance company $1,000. Insurance will say, hey, this is a tier 4. You're going to have to pay $100, right? So you get the coupon card, and the drug company gives you a coupon card, because what the drug company would do is say, okay, well, I'll buy down 75 of that 100. So the patient pays 25. So you as a patient pay 25. The insurance pays 900, and the drug company eats, 75. Now, you might not be paying $1,000, but next year when you look at your premium, you're like, why did it go up $800?
Yeah, right? So there it is.
So you're gonna pay for it, yeah. And so I think I was doing some just basic calculations. If because now this is approved for people who have a BMI above 30, who have one medical problem like diabetes, high blood pressure, high cholesterol, something like that. At $1,000 a pop, if we say a third of our population in Mississippi is obese, that's 1 million people. At $1,000 a month, that's $1 billion
a month.
You start thinking about what you could do.
Who's paying for that?
Yeah. You start thinking, what can we do? We can do better education with children on food. Maybe we can change the quality of food that we see. We can, open restaurants that serve high quality food for $1 billion a month.
We can give everybody a gym membership. Yeah. There's so much you could do with that money.
Yes. And I think that's when, other countries look at this stuff, because to them, they have one single payer. So it matters. If I'm going to take on this cost as a country, what is my return on investment? And for other countries, they might realize $1,000 a month or an extra $1 billion, a month is not worth that. They could take that $1 billion and invest it in something else. Maybe make the city more bikeable, or makes, something else like that. And so, all that being said, that's kind of the way we look at these class of medication. I like how you wrapped it up, Melissa. We probably need to treat it long term, something. But until pharma makes this price better, or we find some kind of program where we incorporate lifestyle changes mentally, while we use this medication, knowing that we can't be on it forever, we're just going to end up yo-yoing.
That's right. Forth. Yeah. We'll continue that up and down cycle that we see right now, and we have seen for every other weight loss solution so far. If there was something that was truly working, we wouldn't be where we're at and, spending billions of dollars every year on weight loss.
Yeah. So I guess to wrap up the drug, the drug is good. It's a good drug. Yeah. It works for diabetes. It does what it's supposed to do. It's fine. B, the drug's weight loss is not sustainable off the medication. So I think we want to hammer that point home. Like people say, well, I'll just be on this for 3 months, then I'll keep. It does not, in the optimum drug trials, it does not work like that, right? So what that means is we do need lifestyle modification, some kind of program, something to help us sustain the lifestyle part of it when the medication comes off. And then 3, cost-effective wise, it is not cost-effective right now. Sure, you can pay it out of your pocket, but $1,000 a month, that's the average. Some are $1,500, $1,200. I mean, you almost might as well get another house. Yeah. Buy a mortgage, or use that money to, like, give everybody a gym membership. Hire, personal chefs, you know, for that kind of money.
Yes.
Yeah. So, all right, Melissa. Questions.
To the questions.
Yes. So I know a lot of our patients have been waiting for these questions. So the first question is, how do you determine if this is healthy for each patient?
Okay. Yeah. So we talked about this a little bit. First of all, want to make sure BMI is in that greater than 30 range. Usually having another health condition too kind of may indicate that we need to be a little bit more aggressive with weight loss, whether that's high blood pressure, diabetes, things like that. But for the most part, if we do find that someone's a candidate, we do just have to weigh those risks and benefits and whether this is something that's sustainable or will be sustainable long term.
Yeah, perfect answer, Melissa. I think it is person by person dependent. You're right. If you have diabetes, obviously that puts you in a different category because we have heart benefit data for you. So, you weigh the risk of this medication actually help prevent heart disease, heart related death. Okay, that might change. But for someone who's, maybe not only overweight, not really obese, this medication might not be the right drug because of the cost and the fact that it comes back, which brings us to the second question, which is any data on what happens when people come off it. We answer that.
We talked about that. It comes back.
It comes back. Yeah. And again, in drug trials, if it happens in drug trials, in real life, it's usually even more so.
For sure.
Yeah. So, and again, insurance coverage, that we don't know. That's up to each insurance. And again, I think I can see why they are nervous because, for some insurance plan, this drug has become the most expensive medication, even passing, Humira, which is a really expensive medication, just because of the sheer amount of people on it. And like I said, I think we did some gross calculations. If we're going to spend that kind of money, we might can think about other things that we can do that's more sustainable for weight loss, right? And the people just asked about how does it work? We talked about the mechanism and how realistic the results are. So we talked about that too.
Yeah, we did talk about that a little bit. And that's what I think the take-home point is. I think everybody just needs to have a really realistic idea of what this medication can do and what it can't do. It's not the sole solution to all of our obesity or overweight problems, and it really takes addressing multiple factors of lifestyle, medication, all of that really all has to come together to have success.
Well, and that is a perfect wrap up, Melissa. I like it. So we're not Debbie Downers. Again, like I said, we're not sponsored by anybody. This is actually just our thoughts. So it's not like we're working for pharma or working for whoever. No. But, we want patients to understand what's actually happening and whether this is the right medication choice for them. Next week, I think after the significant interest in patients want to know about weight loss and obesity, we'll probably actually spend a couple of maybe episodes on obesity. Because I think if we can kind of understand the science behind how obesity happens, we can better understand why certain things work and why certain things don't. And because it's multifactorial, there's a bunch of things to touch on. So I'm thinking next week we touch on the hormones of obesity.
Okay, that's a good one.
So back to biochemistry.
Late night reading.
Lord have mercy. I know. I guess it helps. It expands my knowledge.
There you go.
Yeah. Any last words, Melissa?
I don't think so. I think we covered it.
All right. Well, I think we did a thing.
Yes.
I think it was good. I hope people find it, helpful. We have it on Spotify. We have a YouTube page.
Yes, you can listen on YouTube.
Yep. So Common Sense Medicine with Tim and Melissa on YouTube. Common Sense Medicine with Tim and Melissa on Spotify. So you should be able to find those things. Of course, we posted on our Facebook page at Common Sense Medicine on Facebook. So if you're not following, follow there. I hope you guys have a great day.
Yes. Have a good one.